Good morning, and for those of you who are expecting Keith Harding, I'm a very poor substitute. Unfortunately, Keith wasn't able to join us at EWMA this week, and he's asked me to present on the behalf of the authors the results of this study, but more importantly about the protocol design. That does also lead me to say that I'm an employee of the sponsor, First Kind, who are the manufacturer of the intervention. On to the intervention. So, First Kind manufacture a device called the Gecko. It stimulates at a rate of once per second, 1 hertz, the perineal nerve. This perineal nerve then stimulates the calf muscle. In between that calf muscle, you've got some good meaty veins. They're compressed, and that pushes the blood back to the heart. What does that do? Well, what it does, by increasing the rate of return of blood flow, is you increase the blood flow in the wound bed. Now, if you look at the image on the right-hand side, this is without the device turned on, and you will see that there's virtually zero pulsatility or flux with regards to blood flow in the wound bed. This is a venous leg ulcer. The imaging is laser speckle imaging. When the device is turned on, you'll see that actually the blood flow in the wound bed and in the peri-wound and the flux increases massively, over 260% increase. It's a potential mechanism of action. So if we're going to know this and design a trial where we have equipoise, we need to determine whether this method of action, or potential method of action, can create a study. We can create a study where we can see an improvement in the rate of wound healing. Now, if you look at the graph in the bottom left-hand corner, the grey line at the base represents our current gold standard, multi-layer compression bandaging. Now that's at 40 millimeters of mercury, and every patient who, when I present the results, who was in this study had compression bandaging for the whole duration of the trial, whether they had the intervention or they didn't have the intervention. This means that we can also have the ability to design a pragmatic study, because there's only one thing we're changing, and that's the addition of neuromuscular electrostimulation through the Gecko device. Now, our hypothesis is that when we apply the device, that it will change the trajectory of healing as represented by the lower grey line. And therefore, if we change the trajectory of healing, we'll be able to see a difference. So what's novel about this study design? As you all know, I assume almost everybody in this room has experience with venous leg ulcers. The heterogeneity of these ulcers and their patients, and also the complexity of these wounds, well, it's phenomenal. So how do you deal with that? Well, there is an easy way to deal with that. What you do is you make the patient their own control. So if your patient has a deep, complex wound, then you measure their rate of healing for 4 weeks and calculate that rate of healing. You apply an intervention, and then you do the same thing again. So if the intervention has made a difference, you'll see that. Therefore, with a traditional cohort study, you'll notice that actually it's the complexity and heterogeneity of the wounds that prevent significant differences being realised in these patient populations. However, if you make the patient their own control, you can use a much smaller study, and you've counteracted the impact of heterogeneity and complexity of the wound. So, for the study of the trial, every patient has compression bandaging. They have that for 4 weeks. Half of those patients continue with their compression bandaging for another 4 weeks, and then the other half have the Gecko intervention for that 4-week period. This means, because they're all their own control, if there is a difference, we should see it. Just to give you some background on the population, the only 2 things I really want to point out, both populations who are the patients who received standard of care throughout the 8-week period, and the patients who had the intervention with the neuromuscular electrostimulation, they're all exactly the same. The 2 elements I want to highlight is firstly that most of these wounds were over 10 centimetres squared, and that the patients had their ulcers for about 1.5 years. I think it's the minimum wound period is about 470 days. So, what am I saying? These are older, chronic wounds of a reasonable size. I've chosen a trajectory to show you. By the way, this isn't the best trajectory for the wound healing. These are the patients who were randomized to the gecko arm. The best trajectory is the heels, obviously, wound. So this is just a typical trajectory. The top line is compression bandaging only. You can see an improvement in that patient's wound over the 4-week period of the running phase. But if you look at that compared to when the intervention is applied, the wound appears to heal much more quickly. Let's see what that looks like at a population level. Indeed, if you look at the left-hand graph, you can see the patients who received compression bandaging for the 4-week running phase, when compared to the blue line on that graph of patients who had the gecko for 4 weeks, there's a massive improvement in the rate of healing. This is percentage area reduction, and then the percentage area reduction has gone up by a factor of 2.9 times faster healing rate in the intervention phase when compared to the standard of care phase. Looking at the graph on the right-hand side, the reason that's there is to show that standard of care is constant over the full 8-week period of the trial. And from a statistical perspective, those two bars on the right-hand graph, they're exactly the same. So standard of care, compression bandaging, is constant when you look in a snapshot window of 8 weeks for patients with long-term pressure, venous leg ulcers. In comparison, the gecko device heals those wounds much more quickly. We also looked at pain for these patients, and with the increased blood flow in the wound bed, we hypothesized that the patient's wounds would get smaller more quickly, and therefore their pain would be the patient's perception of pain would be less, and indeed we found that out to be true. As you can see, in the control arms, pain was constant throughout the study arms, but actually when the gecko was applied, the patient's perception of pain was greatly reduced over the study period, and again, this is a significant result. So, in summary, a self-controlled trial design always allows us to have sensitive discrimination with a relatively small number of subjects over a relatively short period of time. And this is an effective alternative to a cohort study. PAR is a useful measurement for assessing wound healing, and intermittent NMES of the common perineal nerve actually reduces pain, the perceived pain of the subjects who are recruited into this study. Finally, the device clearly appears, it doesn't appear to, the device clearly increases the rate of healing for venous leg ulcers. Thank you.